All right, the next organism we're going to talk about is Haemophilus, and we've mentioned Haemophilus before. Now, with Haemophilus, we're talking about gram-negative rods that, remember, grow on what kind of agar? They grow on chocolate agar. Why do they grow on chocolate agar? Because they require X and V factors, heme and NAD. And because there is no hemolysin that Haemophilus makes, it can't access those on blood agar because it doesn't have something that lyses the blood. So we have to lyse the blood for it and culture it on a chocolate agar plate. So it requires X and V. Now, there's something called the satellite phenomenon. This is actually fairly cool. So we are, in this case, able to grow Haemophilus influenza on blood agar if we put Staph aureus in there as well. So think about that. Staph aureus has a hemolysin. We know it's beta hemolytic. Staph will lyse the red cells, giving Haemophilus access to X and V factors. So what you'll see if you streak a nice thick streak of Staph aureus, Haemophilus will form these little tiny pinpoint satellite colonies where staph could actually lyse the blood. So that's what the satellite phenomenon is. Now we're going to talk about two species here of Haemophilus. We'll talk about Haemophilus influenza and Haemophilus ducreyi, two very different organisms where influenza, we think about meningitis and epiglottitis, and Haemophilus ducreyi is a sexually transmitted disease. Now, distinguishing features, what you have to know about Haemophilus is all about the capsule. Remember, it's part of that mnemonic. Some killers have Haemophilus, pretty nice capsules. So, 95% of the most severe diseases caused by Haemophilus influenza were from the capsular serotype B. So we now have a vaccine against that serotype of Haemophilus. It's called Hib for Haemophilus influenza type B, and it's a polysaccharide capsular vaccine, and I'll talk about that when we get to the prevention. Fastidious, meaning it's a little bit picky in how it grows. It requires that X and V. Some people call them 5 and 10, whatever is easiest for you to remember. The reservoir is the nasopharynx, and it's very easily shared by respiratory droplets and shared toys. So again, in that daycare setting, very, very easily spread. Now, pathogenesis is going to go back to the capsule, okay? And it's going to be also important in the diagnosis. So how are we going to look for it? Remember earlier we talked about not using the quelling. Remember that grandma designed years ago and still test. We're talking about latex particle agglutination. That's going to be specific for the capsule. And what virulence factor do you have to have if you're a mucosal pathogen that is worth anything? You got to have an IgA protease. That's the number one means of protection in the mucosa. So if you can combat the IgA and be slippery as well, you're going to do very well in the mucosal surfaces. Now, meningitis. This used to be in the U.S. one of the leading causes of bacterial meningitis in children. And with the advent and addition of the vaccine to the recommended vaccines that children receive, we've seen a serious decline in the number of cases of meningitis due to Haemophilus influenza type B. Does that mean they're not going to ask about it? Absolutely not, okay? They will still ask you a clinically relevant question about Haemophilus influenza, and here's how they'll do it. And see if you can pick up on the clue. You have a 3-year-old immigrant child that was brought into the ER with fever, stiff neck, just lethargic, and maybe a little bit of vomiting. And they gram stained a CSF, and what they found were coccobacilli. And they want to know what the most likely cause is, or what the organism grows on. Anyway, they can ask you a question about Haemophilus. So in that short vignette, I actually gave you 2 clues. The easiest one was that it was a coccobacilli, because Haemophilus influenza is actually kind of a short, stubby rod. So to the untrained eye, it might actually look like a cocci, like our friend strep here, so it might actually look round, but it's actually a short, stubby rod. Okay? So that was the first clue. What was the other clue? The other clue was immigrant. All right? When we say immigrant, we know virtually nothing about the vaccination history. In that case, where there's no history of vaccination, they may mention the child is not up to date on the vaccinations, then you got to consider Haemophilus influenza, and this has been showing up. All right, so you definitely want to be aware of Haemophilus influenza meningitis. Now, what are some of the other diseases? Otitis media. Still, we vaccinate. Remember, just like with strep pneumo, but we're still seeing quite a few cases of otitis media due to Haemophilus influenza. Now, it's usually the non-type B strains that are causing otitis media from Haemophilus influenza. And I can tell you from experience with having kids where you learn a lot about microbiology, even more than the books in the classroom sometimes, that when they have otitis media due to strep pneumo, okay, it's typically just a normal otitis media, whereas a lot of the times, more often than with strep, with otitis media from Haemophilus, they also have conjunctivitis. So you'll look in the conjunctiva and it will be all red. So that may be an additional clue that now we're not talking about the most common cause, which is strep pneumo, but maybe we're talking now about Haemophilus influenza, which is second to strep pneumo as far as the otitis media. Haemophilus influenza also causes bronchitis and pneumonia, typically, again, in people that have either underlying lung disease, like COPD, or people with a smoking history. And they'll have you'll hear it constantly with the crackling and the coughing, and that's very common from Haemophilus influenza. Now, one of the other things that we don't see as often, which is good, is epiglottitis. So since the vaccine, we've also eliminated a lot of the cases of Haemophilus influenza due to epiglottitis. Now, epiglottitis was kind of a harsh disease on kids because with the swelling of the epiglottis, what happens is the kids would get this characteristic, what they would call catcher's stance. So they would kind of crouch over, like if you were watching a baseball game, and you see the catcher down there. But what they would do is kind of drop their heads because that's the only way they could really breathe and catch a breath. Now, at the same time they're in that catcher stance, they're just drooling, all right? So they're crouched over in the catcher stance, like at a baseball game, their heads kind of dropped and they're drooling, and they're just trying to catch their breath because they're having a very difficult time breathing. Now, where I live in Pennsylvania, we have a lot of Amish communities, and a lot of our students go out and they're seeing all these Amish communities that don't really practice vaccination. So they've actually seen cases like this, and they were so excited. They came back and they were like, Dr. M, I saw epiglottitis. It was just like you said. They brought the kid in and he was all hunched over. So that's going to be a big clue for epiglottitis. Now, as far as the diagnosis, remember, you're going to think about the chocolate agar, and you're going to think about the latex particle agglutination, looking for specifically the capsule. Now, how are we going to treat it? Remember, meningitis, cephalosporins, all right? That's typically the drug of choice for meningitis. Now, prevention of Haemophilus influenza is that capsular polysaccharide vaccine, but what they did to make it a better vaccine was they conjugated it to protein. Now, we haven't talked about immunology yet, but remember that B cells can recognize polysaccharide, but in order for the T cell to recognize something, there has to be protein in there. So what they did to make this a T cell dependent vaccine, meaning you're going to get a much better antibody response, is they conjugated that capsular polysaccharide to protein. Now, because it's not a live vaccine, you'll notice one of the common themes is that when we have to give this vaccine, we have to boost multiple times. So we're boosting at 2 months, 4 months, 6 months, again at 15 months. but it's been very, very effective in reducing the incidence of very severe disease with Haemophilus influenza. The last thing I want to mention about prevention is that you can use rifampin, like we talked about for Neisseria meningitidis, to reduce colonization, especially if we're talking about contact with unvaccinated children. This is another thing, in addition to the vaccine that we have, in order to reduce the spread of Haemophilus influenza. Now, the other species of Haemophilus is Haemophilus ducreyi. And Haemophilus ducreyi is a sexually transmitted disease, not one that we see very frequently in the U.S., but when I describe the disease for you, I'll tell you what you're going to have to differentiate it from. Now, the disease itself is called chancroid, and these are very, very painful chancres. So the mnemonic here, which cracks me up, is you do cry with ducreyi. And what they're trying to get you to remember is that it's extremely painful. I myself would cry with any of them, but specifically with ducreyi because it's so painful. Now, in direct contrast of that, you have treponema pallidum or syphilis, and that is a non-tender, non-painful chancre. So that's going to be number one thing you're going to have to differentiate when they're talking about chancroid. Now, open lesions, and this is not unique to Haemophilus ducreyi, are going to help aid the transmission of HIV. So that's something that you're going to need to think about. How are we going to diagnose it? You can diagnose it by DNA probes. Are they going to tell you that? No. So you're going to have to go based on clinical information there. And how do we treat it? We use azithromycin or probably one of the cephalosporins or fluoroquinolone, specifically ciprofloxacin.